everybody. This is Terry with the Premom team, here again with Tina Hickman, nurse practitioner and fertility coach. I think I'm missing something. What else?
Midwife.
Midwife. That's an important one. Thank you. Yeah, really excited. Tina's going to be creating some content for us as we expand more into the pregnancy as well. But today we're going to talk about PCOS and regulation of your cycles. And Tina has some great content prepared for you. And we're also going to answer some of your questions that you asked. So take it away, Tina.
All right. So as Terry said, I'm a women's health nurse practitioner, midwife, and fertility coach. I'm really excited to be here and talk to all you guys. I have some questions that I will answer kind of after I talk to you a little bit about irregular periods and PCOS. And then we're going to open up the floor for some questions afterwards too. So when we talk about normal menstrual periods, so first I'll just kind of go down through what it means to be normal, right? So the big thing when you're talking about periods is just to know if it's normal or abnormal. If you know it's abnormal, then you can find the help that you need. So a normal menstrual cycle is anywhere from 21 to 35 days. So if you're having menstrual periods that are shorter than that duration or longer than that duration, that would qualify you as irregular periods, and that should probably get looked into. Now, regardless of how many days it is between the 21 and 35, if it is happening like clockwork and it's every 35 days, then that makes it normal. Now, if 1 month it's 35 days and 1 month it's 21 days, then that's irregular. So as far as length of your actual bleeding should be about 3 to 7 days. I say 2 to 7 days because some people usually spot on that first day, and then full flow happens the third day. So the first day of your menstrual cycle is actually day 1 of where you have enough flow, you have to wear a pad or tampon. So the amount of bleeding is also something big that you want to look at. So you do not want to have more than 80 milliliters of vaginal bleeding during your menstrual cycle. So to kind of put that in perspective, a tablespoon is about 15 milliliters. So 80 milliliters, you're looking at about 5.5 tablespoons of blood. If you're bleeding a lot more than that, that's probably something that you need to check out as well. So severe pain. So a little bit of pain is normal with your period. But when I say a little bit of pain or normal, I mean pain that is relieved by ibuprofen, Tylenol, Midol, those kind of things. If you're taking those kind of things and not getting relief, or the pain is kind of affecting your daily living, that's too much pain, and you need to get that kind of looked at. So some of the big things that can cause irregular periods are a significant weight loss or weight gain at any point in time. Stress. So stress is a major factor in your menstrual cycles, because if you have, if your cortisol levels are out of range, then this can affect all the other hormones in your body as well. Any kind of eating disorders. So if you have an eating disorder of any type, this can really mess with your periods. And the other one is heavy endurance exercising. So if you're somebody who does like CrossFit or something like that, this isn't necessarily good and healthy for your fertility in your periods. All right. So the reason that we get a period, it's important for you to know why this happens, because if you know why it happens, then you can understand more so why it doesn't happen if you're somebody who's irregular. So every month you have these hormones, progesterone and estrogen, that are working to thicken your endometrium or thicken your uterine lining to nest a baby, right? So our bodies are programmed to get ready for a baby from month to month. So when we ovulate and that is not fertilized, then our body signals to release that buildup of cells in that endometrium, and that gives us our period. So your period cannot happen without some sort of ovulation or surge in LH. So this is why you oftentimes hear providers say, if you're not having a period, you're not ovulating, or vice versa, because the two go hand in hand. So I'm going to talk a little bit about different birth controls and their effect on your period and their effect on your period and regularity after you stop them. So the first one is combination oral contraceptives. So this is just your standard birth control pills, progesterone, estrogen. These act to stop ovulation, to thicken your cervical mucus, and keep that lining in your endometrial thin, so it can't hold a pregnancy even if there was one. This has the hormones that kind of sometimes mimic your body. So after you're through taking birth control or combination pills, you should not have a problem conceiving. That's a problem a common misconception, is that after you take birth control pills, or if you've taken them for a long period of time, that you think that's why it's keeping you from getting pregnant. That could not be more far from the truth. Taking combination oral contraceptives is not going to cause any kind of problem. And in fact, we see a lot of pregnancy rate after stopping those birth control pills. And that's why oftentimes they're used in the infertility world. Okay, so the mini pill is just a progesterone only pill. This one's a little bit different. So this one works to thicken the cervical mucus and thin that lining, but it doesn't stop ovulation. So that is why oftentimes we say, you have to stay on top of it when you're taking it. But that's for people who don't want to get pregnant. But with the mini pill, it is very easy to come off the mini pill, and it may take a little while to get your periods back regular, but should not take more than a month or so, and then you should be able to conceive very easily after that. The vaginal ring and the patch are combination birth controls as well, but they just work a little differently. So again, after these ones, you should not have trouble getting a regular period and getting pregnant. So IUDs. So the difference between the IUDs is one is copper, so it does not have hormones. So it should not affect anything after you quit taking it. Your periods should just continue to be regular like they were before. The Mirena, Liletta, the other class of IUDs are progesterone only. These ones affect you a little bit differently, and it can take up to 6 months for your periods to get regulated after you take that. It does not affect future fertility. So that was one of the questions that I got, is if you have Mirena taken out, how long until you can get pregnant, or can you get pregnant? The answer is it could be immediate. It could be up to 6 months. But pregnancy is very, very possible and happens frequently after Mirena. The Depo-Provera shot. So this is one that is very unfavorable to regular periods and pregnancy after stopping it. So it can actually take up to 12 months to get your period back regulated after the Depo-Provera shot. So this one's a little bit hard. If you're wanting to get pregnant immediately after, sometimes providers can give you a combination birth control pill or some estrogen therapy to kind of stimulate your periods to happen. But that one definitely takes a little bit longer. So if you're somebody who's on the Depo shot and you're wanting pregnancy, maybe you don't even want pregnancy for another 6 months, but it would be worth it to maybe stop the shot and get on a pill now to kind of prepare yourself for when that comes around. Last but not least, the implant or the Nexplanon. So it is a progesterone only as well. So you're going to have that little bit of up to 6 months to get regular again, kind of with the Mirena, but it can also be immediate. But none of these birth controls make us as providers say, oh, you were on this birth control, so you're not going to get pregnant. There's always a way, and there's always a way to get your periods back regulated after you do these things. All right, so we're going to go into a few reasons for irregular periods. There's several different reasons, but I'm going to, after I give you the reasons, I'm going to touch on one a little bit more in detail. So reasons for irregular periods. We talked about stress and things before. One of the big ones is PCOS. So 10 to 20% of people in the US now have PCOS. So it is on the rise, and we as providers are working every day to kind of figure out new ways to work with it, new ways to deal with it. Thyroid disorders, so hypothyroidism, Hashimoto's, all these things are very important. So, getting your thyroid checked and making sure it's in a regular state is important. Cancer can cause irregular periods. Again, that's rare, but it is a cause. Endometriosis, so that's when your endometrial lining kind of implants on the outside. That can cause irregular periods, and pelvic inflammatory disease. So those are all kind of things that you can have in the back of your mind with an irregular period. All right, so on to PCOS. So PCOS is very complex, very complicated. So polycystic ovarian syndrome is what that stands for. Providers are starting to kind of separate them into PCO, so polycystic ovaries, and PCOS, so polycystic ovarian syndrome. Polycystic ovarian syndrome kind of encompasses PCOS as a metabolic disorder. And PCO is just kind of if you have those cysts on your ovaries, right? So polycystic ovaries is when you have a bunch of small fluid-filled cysts on your ovaries that don't tend to regenerate and go away from month to month. This also causes high LH or luteinizing hormone, increased insulin hormone, and increased testosterone. So things like obesity, acne, hair growth, irregular periods, no periods, dark patches on your skin that can be caused by high insulin levels. So those are all kind of symptoms that you can be looking for to see if you're at high risk of PCOS. So the way this works is if you have all these cysts on your ovaries, right, you're producing all of this LH hormone or this luteinizing hormone, which is also the hormone that we look for the spike in ovulation. So if you have PCOS and you're constantly releasing this steady state of high LH, then you can get LH surges or high LH readings throughout your entire cycle. So that was also one of the questions too, is why am I getting a spike in LH 8 days post ovulation? Or why am I getting high LHs all the time, right? So that makes it hard to show when you're ovulating. And that is because when you have all these cysts on your ovaries, or your pituitary gland doesn't quite know what's going on, they're constantly releasing the steady state of LH. So it kind of makes it hard for your body to comprehend everything that's going on. The other thing with that is when the LH is high all the time, then it's signaling these ovaries to produce more testosterone. So as we produce more testosterone or androgen, then that's why you get the acne, you're getting the hair growth, okay, all these kind of things. So high levels of androgens, which is testosterone, is also very signifying of PCOS. And then to the insulin. So insulin is another hormone that gets elevated in the metabolic part of PCOS. And insulin kind of, if you have those dark spots on your skin, sometimes under the armpits, on the neck, that is very, very signaling of high insulin levels. Okay. Let's see. So testing for PCOS, you're going to want to get a luteinizing hormone and a follicle stimulating hormone. So we look at the ratio in these, and we look at the elevation of the LH to see if it's out of range. You're going to get a testosterone level. So this will tell us where your free testosterone level is. Shouldn't be more than 5. So if it's higher than that, then oftentimes your provider is probably going to want to treat you with some birth control to lower those levels. The other is the insulin. So we're going to check a fasting insulin level to see if that's elevated. We don't want it higher than 20. So if it is, we talk about things like metformin, things like that. So metformin usually is not used for PCOS unless you have that metabolic part of it. So unless you have that increased insulin level. And then they're going to check a DHEA level. So if you just have the cysts on your ovaries, then you're given the diagnosis of PCO. If you have the high testosterone levels, or the high insulin levels, or the high LH, FSH, then you're given the diagnosis of PCOS. If you have only high testosterone levels, you can be treated with just birth control. If you have just the insulin, then you can be treated with just metformin. If you have both, then a lot of times we use a combination of the two for a good 3 to 5 months to regulate those periods before we look at getting pregnant. So one thing I kind of wanted to touch on, a lot of people are doing, they have PCOS, but they're given progesterone to start their period, and then they are given ovulation medication right as soon as they start their period. This sometimes works, and this sometimes works wonderfully. And for some people, that's the only option. But the problem with this is we're only masking the problem of PCOS, right? So even if you get pregnant, that's wonderful, but you're still going to have that high insulin level and that high testosterone level working against your pregnancy. It's going to make you unhealthy. It's going to make different things just not go so perfect. So I would encourage you to treat your PCOS for that few months before taking that ovulation medication. This is hard for some patients because when somebody finally comes to you after a year of trying to get pregnant and you tell them, I want to put you on birth control, that is not what they want to hear, right? But that birth control is a really good therapy for irregular periods, and especially PCOS going forward. And it can actually make your trying shorter in duration in the future. So just don't be scared of using that birth control. It's a really good proven treatment for PCOS. Okay, so let's see. So that's it for that. I'm going to go down through the questions that I had and make sure I kind of hit everything. So things that you can do to help have regular periods. So we touched on it a little bit already, but you just want to maintain that healthy weight, do light exercise, watch your diet, decrease stress. Don't do any of that high endurance exercising because that can actually not be that good for your body, right? There's a reason why things like CrossFit and stuff is so hard. It's because it's hard on your body too. So when you're trying to get pregnant, just be careful with that really hard, intense exercise. I know that you're thinking that these things are helping, but you just want to be careful. And I just wanted to touch a little bit too on weight loss, because I know that a lot of women get frustrated when they go in to see their provider and their provider says, oh, you lose weight and then come back and see me. I don't love that answer, but there's also some truth to it. So with PCOS, you also have trouble losing weight. So it's kind of like a double-edged sword. But the biggest reason we tell you to lose weight is because there's actually scientific reasons why that is. So the more body weight that you have, the more estrogen that you're going to produce. Okay. So, and also the more testosterone that you're going to produce, which also is going to increase your insulin level. So when we tell you to lose weight, it's not just because we think you're overweight and we think, it'd be better for you. It's because it actually is going to decrease those hormones levels that are causing this PCOS. So I just kind of wanted to touch on that briefly. So let's see. So Mirena and conceiving, we already touched on that one. LH surges and PCOS. So we talked about the constant cyst causing hormone imbalance and giving you that high LH reading. So the HSG. So this is a little bit off topic, but so what an HSG is a histosalpingogram. So what your provider is doing is looking under ultrasound guidance at your fallopian tubes and your pelvic cavity. So he or she will put a dye, a liquid dye into your uterus, and it will travel up to the top of the uterus and down through the fallopian tubes. If we see that fluid spill at the end of your fallopian tubes, then we can say the tubes are open and a blockage is not the reason for your problem. Now, the other side of this is some providers are actually doing HSGs more often because it quote unquote cleans out your tubes, right? So just think of like, I don't know, you could just get debris in there and stuff over time, and just think of like washing the dishes, right? You're just kind of washing it out after everything it's been through over so many years. So yes, there has been shown an increase in pregnancy after an HSG, and that's simply because you're cleaning out those tubes and you're leaving clean paths for those eggs to travel. So the other thing with that is anybody that has PCOS, I would encourage greatly that if you are treating yourself with the birth control or the metformin for 3 to 5 months, get that HSG, but don't get the HSG until your last cycle of birth control and metformin. This is because you're going to clean out those tubes right before the month you're going to try to get pregnant. So that is going to give you, as somebody who has PCOS, the highest chances. Treat yourself for 3 to 5 months, have the HSG, and then move forward with fertility control. All right. So I have a 35-day cycle. Is that normal? Yeah. So as long as it's happening 35, give or take 1 day every month, completely normal. On the other hand, I had somebody saying 40-day cycles. This is not normal. So this is something that you probably want to look into. Now, if it's 40 days on the money, so if you are having a period every 40 days, every single cycle, that can be considered and ruled normal after proper testing. But definitely a cycle of 40 days, you want to get checked out. Post miscarriage cycles. So this is a tough one because everybody is a little bit different as far as miscarriage goes. So if you have a DNC, then we are mechanically, as providers, cleaning out your uterus for you and giving it a clean slate. So just kind of speeding up the process, right? If you miscarriage on your own, then it's your body's responsibility to clean you out and get a clean slate ready for pregnancy in the future. So it's normal for periods to be a little bit heavier after a miscarriage. This is why I usually tell people to give it a good solid 3 months before trying to conceive again, because your body has a lot of upkeep to do or a lot of repair to do, right? They have to clean out that uterus, and then they have to build that line. It has to build that lining back up in order to promote a healthy pregnancy in the future. But as far as miscarriage itself, causing irregular periods indefinitely for the future, that should not be the cause. So if you are having irregular periods longer than 3 months after your miscarriage, I would certainly go see your provider and figure out what's going on. It's possible that you could have some retained products of conception, so all the hormone was not removed during your miscarriage. Lots of options. So if you're still having irregular bleeding or no period after month 3 after a miscarriage, I would definitely get checked out. Last question. So bicornucate uterus and PCOS. So we already talked about PCOS. Yes, it is possible to get pregnant when you have PCOS if treated, right? So PCOS is usually not curable, which means we can't get rid of it, but it is 100% treatable. So we can treat it and, hopefully get pregnant in the future. So just for people listening that's not sure what a bicornucate uterus is, that basically means that you have 2 uterine cavities. So a lot of times I explain this a little bit as, think of a heart. And if you think of the heart and you think of the middle point of the heart going down just a little bit too far, that is kind of what a bicornucate uterus looks like. It's almost like there's a septum or a wall separating 2 different sides of the uterus. So with that being said, yes, it can be difficult to carry a pregnancy when you have this septum kind of impinging on your baby burrowing. But everybody's degree of bicornucate uterus is different. So it all depends on how far that septum comes down. This also can be fixed or removed if it's too bad. But I have seen several people in my experience get pregnant with a bicornucate uterus. So it's definitely possible. If you've been trying to get pregnant for a long period of time, then I would, go see maybe a gynecologic surgeon or somebody who specializes in this. But I would definitely get your PCOS under control first. Once that is under control, periods are back regulated and things, then address the bicornucate uterus, because the bicornucate uterus in and of itself may or may not be keeping you from pregnancy. All right. I think that's all for my questions that I had.
Yeah, I was just thinking, I think you covered quite a bit there. And thank you for breaking down some of those topics so nicely, like when you were talking about the difference between PCOS and PCO. That was new for me. That was neat. And then the differences between the different types of birth control and how that can affect your cycle. Because I know that question does come up a lot for our users. So to hear the different examples and how that can change is really helpful. If you are watching live, we're going to go a little bit longer. So if you have any questions about PCOS or about cycle regulation or something that you heard Tina mention, please feel free to jump in with a question. And I had a couple questions. Oh,
sorry. I was going to kind of just touch on diagnosis of PCOS real quick. So, because I gave you a lot of, things that can make you think you may have PCOS. So in order to get that diagnosis, you don't have to have all of those things. So I want to make that clear. So again, you can get a diagnosis of PCO just from the ultrasound. If you have that on the ultrasound, that will trigger blood work to screen for the metabolic part. But if you have blood work done and you have, say, you're overweight and you have a high testosterone level, that already puts you in the diagnosis for PCOS. If you have irregular periods and a high insulin level and high DHEA, that puts you in the category. So you only really need three of those several kind of symptoms or markers to have the diagnosis, or you can also be diagnosed by ultrasound alone. So I just kind of wanted to make that clear, even if you have maybe one or two of those, it would still be worth getting checked out.
Okay, great. And you talked about miscarriages. I had a question about that. I was thinking as you were speaking. You mentioned like waiting 3 months before trying to conceive again. Does that vary on how late into your pregnancy the miscarriage is, or is it the same advice you give?
It's pretty much the same advice, because again, the treatment for that is usually the same. So if it's deemed intrauterine fetal demise, so if it's further than the first trimester, a D&C is usually still how they handle that. So it's still going to recover your body just the same as if it was in early first trimester.
Great. And can you talk a little bit about tracking with your period and spotting versus flow, and maybe spotting during the cycle? I know that question comes up quite a bit.
Yeah. So tracking your period, of course, Premom has a really good way to track that. But, just write it on a calendar and see what's happening, and, write all that down for 3 months and then look for patterns. Patterns are really important. So if you don't have any patterns, then that's a red flag. But if you're having kind of the same patterns every month, it makes us easier for providers to kind of help you figure out what's going on. As far as spotting through the month when you're not on any kind of birth control or anything like that, that's usually something we need to look into. But you need to remember that just because you're spotting, it's not always intrauterine, right? So it could be cervical. You could have an inflamed cervix. You could have, some kind of tear or something vaginal. So you just want to make sure that bleeding is actually coming from your cervix and endometrium as well. If you are having constant spotting throughout your cycles, then this is something that needs to be looked into. A lot of times it can be a hormonal issue, because as a general rule, if you're spotting or bleeding throughout your cycles, then you may be ovulating at a different time than what we were previously thinking. So that's definitely something you want to talk to your provider about.
Okay, and we do have a question. Did you touch on Nexplanon?
Nexplanon. So yeah, that was the progesterone implant. So that's the one that I talked about, that it is pretty immediate, or it can be immediate when you get off of it. But again, it's progesterone only, so it's going to work a little bit like Mirena, in which it can take up to 3 to 6 months to get that period back regulated. Again, that's just because, we weren't introducing estrogen and periods. The most common symptom when you have the Nexplanon is irregular periods. So it can just take a while to get that period regulated when you take it out. But again, it can be immediate. But I just urge people that are on any kind of progesterone only birth control, if they're wanting pregnancy within the next year, but just not yet, or they're going to try in 6 months, say, I would get it taken out now, start on oral contraceptive, combination oral contraceptive with estrogen and progesterone. And then that way, when you're ready, you can go off the pill and try to conceive immediately.
I had another thought and I lost it. Let's see if it comes back. I think it was about irregular cycles. Do you have any further tips of things that have been successful for people you've worked with, women you've worked with, as far as getting your cycles regular again?
Again, there are, like I said, the stress reduction and all that kind of stuff. There are several herbs and supplements and things that you can do. I'm not going to touch on that just because I don't want somebody who shouldn't be taking them to start taking them and then it be a disaster. But there are several things you can, research it. There's lots of things online, but you just always want to talk to your provider before taking those things, because it's very dependent on your medical history, all that type of stuff. So I would definitely, it's worth looking into. As I said, I'm a midwife, so I love herbs, I love supplements, I love oils, I love all those things, and I believe in them greatly. But you want to make sure you're getting the correct combination. If that's something that you're interested in, I'd love to see you on Premom, and we can talk about it a little further. But as far as giving a general Facebook audience advice on that kind of stuff, I don't want to go there yet.
I love that. Thank you. Because I know in this group, it does come up a lot and people are always saying, what are you using? What are you using?
Yeah.
It is, like you said, really important to make sure that you have something catered to your own body, right? Your own, like you said, your own history and what you need. Awesome. All right. I think that's it. So as Tina said, you can have a consultation right with her right in your Premom app. So be sure to check her out. If you go to more, then schedule a consultation, you can find our providers there. You can find Tina under Nurse Practitioners. And thank you very much, Tina, for joining us today for another fantastic.
Yeah, thank you.
You're
Thanks.
welcome. We'll see you again soon.
All right, sounds good. Bye.